What's up, everybody? I'm Dr. Garrett Rossi, a board-certified psychiatrist, and I've been making mental health content here for a while, and I love nothing more than talking about mental health treatment, everything to do with psychiatry, all about what I do, how I treat patients, what medications I use, etc., etc. And if you're new to this channel, please consider subscribing. It really helps me to know that this information is valuable to you. And if you're a returning viewer, thank you so much for your love and support. It does mean a lot to me. It really keeps me going producing these videos. So without further ado, today's topic is going to be, how do these orexin blocking medications treat insomnia? Now, this is a good question. These are newer medications and it's a bit of a long story, but it's well worth it. And you're going to hear all about it here in this video right now. So sleep is a mystery even to those who study it in great detail. So there's a whole branch of medicine called sleep medicine, where all those individuals do is focus on treating sleep disorders. However, even those individuals don't really fully understand why it is that we have to sleep, and this has always been an interesting question. Now, we spend roughly 1/3 of our lives in this state of suspended animation, sleeping, right? And most people are looking forward to that. So I've had a long, hard day at work. Maybe I just finished up a 24-hour call shift. Whatever the case is, I'm looking forward to laying down in my bed and going to sleep. Now, for some people, that is not the case. For some people, staying asleep or getting to sleep is literally a nightmare. And as a psychiatrist, one of the things you spend a lot of time doing is figuring out how to get people to sleep, and for various reasons. For example, we might have somebody who presents to the hospital acutely manic, they haven't slept in over 7 days, or they've slept very little in that 7-day period, and one of your jobs, of course, is to help them get to sleep, because once they get to sleep, it seems like their symptoms of mania actually improve. Even if there are residual symptoms that need treatment, they start to get better when they start sleeping. The same thing can be said for people with major depressive disorder, where sleep disturbance is a common symptom. So say this is the individual who hasn't slept in the past 3 months very well, and of course, as you improve their sleep, their depression also improves. So it's a big part of what I do no matter what. But sleep disturbances are not always secondary to another psychiatric illness, for example, major depression or bipolar disorder. Sleep disturbances can be primary disorders, such as insomnia disorder, and in the next section, we're going to define the DSM-5 criteria for insomnia disorder and explain a little bit about how one would make that diagnosis. So let's start by talking a little bit about the DSM-5 criteria. And if you follow my other social media posts on Instagram or on LinkedIn, then you know I'm not always the biggest fan of DSM-5 and the criteria and all this stuff. However, in this case, it's important to be able to know what constitutes an insomnia disorder and what are the key symptoms that we are looking for to make such a diagnosis. Now, when the DSM-5 defines insomnia, they call it a dissatisfaction with the quality or quantity of sleep and at least one of the following. So first point is you have to have some dissatisfaction with the quality or quantity of sleep that you're getting, and you have to have at least one of the following things. Number 1, difficulty initiating sleep. Number 2, difficulty remaining asleep or maintaining sleep. And number 3, early morning awakenings. Now, those are very common with disorders like depression, but here you have to have that dissatisfaction in the sleep quality or quantity, and then one of those 3, either difficulty initiating sleep, difficulty maintaining sleep, or early morning awakenings. And this must occur at least 3 times, so 3 times per week for 3 months. There also must be some type of distress associated with it or functional impairment. So the person, in order for anything to be a disorder, it actually has to be disturbing you or causing a problem. There are examples in the literature of people who only slept like 1 hour a night and were perfectly fine. Now, of course, that's the very rare outlier case, but the point is it has to be disrupting that person's function. Those individuals who sleep only 1 hour a night and are completely functional, they go to work, they take care of their families, they do everything they need to do, then it's not really a disorder now, is it? So with that said, what you would move on to is it can't be explained by another psychiatric disorder. That was my point at the beginning when I said it can be part of mania, it can be part of depression, it can be part of a lot of other psychiatric disorders, PTSD, for example. Now, there has to be some loss of function. It can't be explained by another psychiatric disorder, and it also can't be explained by another medical disorder, say something like sleep apnea. So that is how the DSM-5 defines insomnia disorder, and how we're going to kind of talk about it here in the context of orexin medications. Now, insomnia can be divided into two main types. Obviously, there would be a short-term insomnia, and then there would be a more chronic insomnia. So short-term insomnia is a little different because it's related to an identifiable stressor. So this could be similar to, say, an adjustment disorder with depressed mood. Something bad happens in my life, I experience an acute stressor. Say, for example, I have the death of a loved one in my family. Say I'm going through a divorce. Say I'm in an argument with a loved one. All of those things could be examples of acute stressors that would result in short-term insomnia. And this will only typically last for a few days to a few weeks, and it usually resolves once that stressor is removed. Now, what we're going to be talking about here is obviously the people who have a more chronic insomnia. They have problem all the time with either getting to sleep, staying asleep, or having good sleep quality or quantity. Now, this situation is captured by the DSM-5 criteria that I discussed above, and this is a type of insomnia that usually needs some type of treatment, whether we're talking about cognitive behavioral therapy for insomnia, or we're talking about medications like this example in the video we're going to be speaking about a little bit later. Anytime you're thinking about a disorder, another important thing to know is how often does this occur in the population? So what is the incidence or prevalence of insomnia disorder in the population? Now, there are various studies, and every study cites a slightly different number, so it's hard to say with certainty exactly how prevalent this is in society or in the world. However, the estimates for the prevalence of insomnia or chronic insomnia are somewhere between 10% to 30% worldwide. So 10 to 30% of the population worldwide experience chronic insomnia or insomnia disorder. It's most common in older patients, so older adult patients. It's also more common in females, and it's also common in those who have a medical or psychiatric illness. So now that we have an idea of what insomnia is, how the DSM-5 is going to define it, the differences between chronic and short-term insomnia, as well as the epidemiology associated with insomnia, we can begin talking about how orexin plays a role in insomnia and what orexin does. Now, you may have already noticed that orexin can go by another name. That other name is called hypocretin. So orexin or hypocretins, if you hear either of those terms, they're really used interchangeably. So they're kind of mean the same thing. Now, we can define it a little more technical here, but I don't want to for this video because it's a little bit beyond the scope of what we're trying to discuss. So there's two names for these peptide neurotransmitters. So first of all, orexin is a peptide neurotransmitter, and the reason that there's two names is because this was, believe it or not, simultaneously discovered by two separate teams of investigators. So there were two separate research labs who both discovered the same neuropeptide or neurotransmitter here, and they named it slightly differently because they had different ideas about where it came from. So hypocretin was named because they noticed that this neuropeptide or neurotransmitter came from the lateral hypothalamus and that it resembled a gut hormone, secretin. Orexin was used by the other lab because they noticed that this had an appetite stimulating effect, and so thus orexin or orexigenic would mean appetite stimulating. So that's how these two names came about. Now, for simplicity, I just want to stick with orexin. I think that's the more commonly used term, at least for the medications, and also when describing the neurotransmitter itself. When you're talking about the gene or the genes responsible for this neurotransmitter, then you can talk about hypocretin. So, orexin neurons are located primarily in our hypothalamus. So it's part of the brain. It's kind of largely seen as a regulatory center of the brain. And I'm going to give you a diagram here to give you an idea of where that's located. So orexin neurons are located in the hypothalamus, and these neurons are known to degenerate in a condition you may have already heard of. So this disorder, psychiatric disorder or sleep disorder, is known as narcolepsy, and it's characterized by an inability to stabilize the wakefulness period. So when somebody is supposed to be awake and functioning, they're unable to stabilize it, and it results in these things called sleep attacks throughout the day, where the person rapidly falls into REM sleep. Now, the loss of these neurons prevents wake-promoting orexin. So orexin as a neurotransmitter is stimulating. It keeps you awake. It regulates those areas of the brain responsible for wakefulness. So obviously, if you were to lose those neurons, then you would not be able to maintain your wakefulness state, or it would be unstable, such as in examples of narcolepsy. So this is released during wakefulness periods, and it's used to stabilize the wakefulness period, and it doesn't result in somebody developing, like I said, sleep attacks such as narcolepsy. So for simplicity, I'm going to use the term orexin here. Now, the orexin neurons are located primarily in a part of the brain known as the hypothalamus, and we're going to go to a diagram real quick here to show you what the hypothalamus looks like, where it's located. And these neurons are known to degenerate in a condition you might already be familiar with, and that condition is narcolepsy. So in the disease narcolepsy, which is a sleep disorder / psychiatric disorder, it's characterized by an inability to stabilize wakefulness, and that results in sleep attacks throughout the day. So the person could suddenly fall asleep out of nowhere during the day when they should be awake and have no issue maintaining their wakefulness. Loss of these neurons prevents the wake-promoting orexin from being released. So orexin as a neurotransmitter is stimulating, it's going to help promote wakefulness, and if you have loss of those neurons producing it, then obviously you're not going to have orexin there to be released, and this will make the wakefulness period destabilized, such as in the example of narcolepsy. Now, these orexin neurons will produce two types of neurotransmitters. So this is kind of easy and nice because the terminology is easy to understand. The orexin neurons will produce two neurotransmitters, orexin A and orexin B, which are released all over the brain. So these are kind of released globally because remember I said they're wake-promoting agents or wake-promoting neurotransmitters, but there are especially high concentrations released in the monoamine centers in the brainstem. So here we go again, monoamines and psychiatric disorders, we're talking about it here. So monoamines centers of the brain have high concentrations of orexin A and orexin B neurons that are going to be releasing these neurotransmitters, orexin A and B, in those locations. Now, the orexin A and B will then bind to two receptors. So there's two specific receptors that are sensitive to these neurotransmitters, and that is orexin 1 and orexin 2 receptors. So again, pretty easy, right? The neurotransmitter itself is orexin A and orexin B, and then those neurotransmitters, orexin A is going to bind to orexin 1 and 2 receptors, and the same thing for the orexin B. So kind of easy to keep the terminology straight. Orexin A and B regulate other processes in the body as well, so we're going to flip to a quick diagram here to show you what those other processes are, but things such as feeding behavior and reward pathways are also regulated by orexin, so you might be able to see where there's potential other therapeutic interventions you could use, such as addiction, for example, in the reward pathway. Now, during wakefulness, the orexin neurons are constantly firing. We call this tonic or tonic firing of the neurons. And essentially what that means is that it's constantly firing, constantly releasing orexin A and B, and that's going to stimulate those orexin 1 and 2 receptors to maintain and promote wakefulness. Now, the orexins may not be arousal neurotransmitters themselves. So we might be thinking about, you might be saying, well, it's wake promoting, it's responsible for the arousal. It's actually not. What it does is it regulates those and mediates wakefulness by regulating arousal neurotransmitters such as acetylcholine, dopamine, histamine, norepinephrine, and serotonin. So again, those monoamines along with histamine there as well are going to all be regulated by orexin neurotransmitters. Now you may be saying to me, Dr. Rossi, why does orexin antagonism work for insomnia? So that's a good question, and it's one that we want to try to answer here. Now, both of the medications that I'm talking about here, which would be Lemborexant and Suvorexant, are both going to work by the same mechanism of action. They're also going to share similar side effect profiles and similar properties overall because they're essentially working by the same mechanism. So both of these medications work by blocking orexin 1 and orexin 2 receptors. So these are going to block the orexin receptors and prevent the wake-promoting orexin A and B from stimulating those receptors. Now, if you followed the discussion so far, then it makes sense, right? Orexin A and B are wake-promoting or wake-modulating neuropeptides, and if we block their ability to bind to the orexin 1 and 2 receptors, it should regulate key wake-promoting areas of the brain and induce sleep. In some ways, these medications actually mimic the effects of narcolepsy, where the patient will rapidly enter REM sleep at inopportune times throughout the day. Now, the effects of transiently blocking orexin 1 and orexin 2 receptors is not entirely the same thing, but it does help to conceptualize the mechanism of action for you guys here. Now, the medications have been found in randomized controlled trials to do a lot of different things in terms of sleep improvement. So one of the things that they do is they reduce the time to sleep onset. So when I take this medication at night, it reduces the time between when I take it and lay down to fall asleep and when I actually fall asleep. It also reduces time awake after sleep onset. So this would be like somebody who is waking up throughout the night. It will reduce the number of times somebody is awake throughout the night after sleep has set in. And it also increases total sleep time. So this has been found in the randomized controlled trials. This is what led to the FDA approval for insomnia disorder. Now, a meta-analysis found that these medications also improve not only those sleep parameters, right? Because you might say, well, so what? It improves the person's sleep onset, reduces their time, awake time after sleep onset, and increases total sleep time. But does it really improve the patient's subjective experience? Well, this meta-analysis actually found that it did improve subjective sleep onset, subjective total sleep time, and sleep quality overall, indicating that these medications have real-world, noticeable improvements in sleep by the patients who are taking them. And there was another network meta-analysis that found that orexin antagonists or orexin blocking medications were superior to other sleep aids that are commonly used. And those things include benzodiazepines, Z drugs like zolpidem, for example, sedating antidepressants such as trazodone or mirtazapine, and melatonin receptor agonists as well. So these medications seem to work better than all those other medications that are commonly used for the treatment of insomnia. The two medications that we're primarily talking about here are Suvorexant or Belsomra, and this one was FDA approved in 2014, and that was followed by Lemborexant or Dayvigo in 2019. So they're, again, same mechanism of action, similar medication, but one was approved in 2014, the other was approved in 2019. And both of these, I want to point out that both of these are considered Schedule IV controlled substances in the United States, so they do have a low but potential risk for abuse. Now let's talk a little bit about dosing. So Suvorexant is dosed initially at 10 milligrams once per night, at least 30 minutes prior to sleep. So when you go ahead and dose this medication, start at 10 milligrams, you want to do it 30 minutes prior to sleep. And another very, very important point that I always point out to patients is that it's not recommended to take this medication if there's not at least 7 hours of sleep time remaining. So you want to make sure you have enough time to sleep, because you don't want to have some of the potential next day side effects like sedation, for example, decreased alertness, decreased motor activity, which could impair your ability to, say, drive your car. So you want to make sure you have adequate amount of time to sleep. I wouldn't want to take this medication when I, was out all night and got home, super late and I only have 5 hours to sleep. Now I probably should skip that day because I could run into problems the next day. So at least 7 hours of sleep time remaining, take it at least 30 minutes prior to sleep, and you do not want to take it with food because that can delay the absorption of the medication, and of course that could mess you up the next day as well. If someone tolerates the medication, but they don't have a full response to it, they're not fully cured of all of their symptoms, then you can increase the dose to a maximum of 20 milligrams per day at bedtime. And the medication is not restricted to short-term use, so we have randomized controlled trial data that can be evaluated out to 1 year. So this medication can be continued, and again, doesn't have the risk for things like withdrawal syndromes associated with benzodiazepines or Z drugs. Now, Lemborexant is started at 5 milligrams once per night, immediately before bed. And the same recommendations apply. You want to have at least 7 hours of sleep time. And if the patient doesn't respond to the 5 milligram dosing, you can increase to a maximum dose of 10 milligrams at bedtime. So we have to talk about it. We always have to talk about it, the side effects, because people want to know, what are the potential risks of taking this medication and what's the downside to it? Now, the primary side effects actually aren't that bad with this medication. The primary side effects include things like sedation or feeling tired, right? Especially like the next day if you take the medication too late at night. Headaches and abnormal dreams. Those are the three big ones. So sedation, headaches, abnormal dreams. Now you might be saying, what are some of the actual percentages? What is the numbers here? Now, I looked at this for the Lemborexant medication. I didn't look at it for Suvorexant, but these, again, are similar medications with similar side effect profiles and will have similar percentages of patients who experience these side effects. So for Lemborexant, the sedation and fatigue were found in 6.9% of 5 milligram users and 9.6% of 10 milligram users, and that's compared to placebo at 1.3%. So sedation and fatigue are problems with this medication, but not super common, right? I always say to you guys that any side effect that occurs in 10% or more of the people taking it, that's a very, very common side effect. If it's less than 10%, it's not as common. Now, headaches were found in 5.9% of the 5 milligram users and 4.5% of the 10 milligram users, which is kind of interesting. There was less headaches in the higher dose. And that's compared to 3.4% in placebo. So you can see even the placebo group had a pretty fair amount of headaches. So I'm not really sure that the headaches were directly related to the medication, or it wasn't just something that was happening in general. Abnormal dreams, so this could be nightmares or things of that nature. This was seen in 0.9% to 2.2%. So again, that 5 milligram dose group had 0.9%, the 10 milligram dose group had 2.2%. And that's compared to 0.9% for placebo. So actually at 5 milligrams, the risk of having abnormal dreams was pretty much the same as placebo there. Now the uncommon side effects that can occur, and these occur in very, very low percentages, approximately 0.1% for hypnagogic. So hypnagogic hallucinations are hallucinations as you're going to sleep. As I'm falling asleep, I experience auditory, visual hallucinations, etc. And this can occur in 0.1% of those using the medication. And sleep paralysis. And sleep paralysis is basically a situation where you wake up, but you cannot move. You're not able to move. You kind of know everything that's going on, but you just cannot move your body. So sleep paralysis occurred in 1.3%. So again, very low, but still something to be mindful of. There is some risk for dose-dependent reductions in alertness as well as motor coordination. And I mentioned that idea that if you don't have at least 7 hours to sleep, you should not take the medication because, again, it can reduce your alertness, your motor coordination, and of course that would impair your ability to drive a car. So we wouldn't recommend that you drive a car if you're feeling that way or you took the medication too late at night. And obviously this is dose-dependent changes in alertness and motor coordination. So you're going to want to use the lowest effective dose of the medication. If you can get by with, say, 5 milligrams instead of 10, great, because there's less likely that you're going to have these problems. The risk for abuse or addiction here, not necessarily addiction, but abuse, let's just say abuse. The risk for abuse is low, making sure that there is not a history of abuse of sedating medications such as benzodiazepines or Z drugs when you're taking the patient's history and you're deciding to prescribe this medication would be a good idea. And of course, monitoring for any abnormalities in prescribing patterns, such as somebody coming back early, saying that they ran out of medication early or they lost the medication completely. Patterns of behavior like that may indicate that abuse is occurring. I only want to briefly talk here about the pharmacokinetics. So the effective half-life is 17 to 29 hours. So that's always important to know because it kind of tells you how long this drug lingers around in your body and how long it takes to fully clear. It's metabolized by cytochrome P453A4 primarily. So whenever I'm prescribing the medications, I think I've said this to you guys before, I will use a drug interaction calculator to kind of take a look at all of the patient's medications and make sure they're not on 3A4 inhibitors or 3A4 inducers, in which case I would need to adjust my dose accordingly, either down, lower dosing if there's an inhibitor, and obviously higher dosing if there's an inducer. And I've already said to you guys another important point, that absorption will be delayed by the presence of food, so it's not recommended that you eat before you take this medication, because if you delay the absorption of the medication, you're also going to delay the onset of the effect and potentially result in that decreased alertness and sedation and fatigue the next day, impairing your ability to drive. So don't take the medication with food. So I want to conclude this video by talking about what makes these medications clinically useful and why you might want to use this medication over another option. And then I'll talk about some of the downsides to this medication as well, because there are some reasons that maybe this isn't the best choice for some patients. So why do I think this is useful clinically? Number one, there's a decreased risk for abuse. And that's really, really important because, as I said before, the Z drugs like zolpidem or benzodiazepines have significantly higher rates of abuse, and they really shouldn't be used for long-term treatment of insomnia. They should really only be used in the short term if you're going to use them at all. So there is more risk there, and there's also no risk with these orexin medications for life-threatening withdrawal syndromes such as you see in benzodiazepines. So it's a better option, I think, from an abuse potential. It's also a better option because it doesn't have any identifiable withdrawal syndrome. Now, these medications can produce meaningful changes in sleep. We know that. And not only do they produce meaningful changes clinically, meaning that like your sleep time increases, the number of times you awaken throughout the night decreases, right? It's also meaningful subjectively. We have data to prove that patients feel better on this medication. Patients sleep better on this medication subjectively. So I think that's important as well. We're not just talking about monitoring parameters here, we're talking about real-world experience of patients. These medications may be effective for patients who have failed other options for insomnia treatment. So if a patient's tried a benzodiazepine, a Z drug, a sedating antidepressant, or a melatonin-based drug, then the reality is that this medication might be the one that helps them. So if they haven't responded to other medications, you might want to try the orexin blocking medications. Now, orexin-based medications may also improve other psychiatric disorders because this is important. There are studies underway looking at adjunctive treatment of these medications for major depressive disorder and other anxiety disorders, and that's currently underway. We'll see what the results show. And because these drugs actually affect other things besides sleep, I said they regulate things like the reward pathway and feeding behavior, there may be other potential uses for them. One of the big ones that's important to me, being someone who loves addiction treatment and studies addiction treatment greatly, I would say that substance use disorders, including alcohol use disorder, cocaine use disorder, and opioid use disorder, may be potential places where this medication could be effective. And to wrap it up, the downsides here, number one, the cost. These medications are expensive. A quick search found that Lemborexant costs approximately $300 per month for a 10 milligram tablet. So 10 milligram tablets cost $300 a month to take, so you would get 30 10 milligram tablets for 30 days. There is still potential for abuse. So what we found is that in higher doses, say 40 milligrams of Lemborexant, it actually produces similar effects or similar sedating effects to 30 milligrams of zolpidem. So somebody who is prone to abusing sedating medications may potentially abuse these medications. So it's not completely free of abuse potential. And I think finally, it's still not perfect. You know, it doesn't cure everybody's insomnia. It doesn't work for every patient. Now, while it improves sleep overall, it improves subjective quality of sleep as well, it's not going to work for every patient. And the effects overall, when you look at the actual times for, say, sleep onset, number of awakenings, etc., it's a moderate effect for insomnia. So it's, again, not perfect, not going to treat everybody's case, but is a pretty good step up from some of the other medications we've had previously. So that concludes the video. Thank you guys so much for watching, and if you haven't liked the video and subscribed to the channel, I'd love for you to do that now. And please drop your comments and questions below. I will try to get to them as soon as I can.